talk to us about implications of the gut microbiome in cancer. And this is a very big area because there were three high-profile papers within the last year or two on the role of bugs in cancer immunotherapy. And they all showed that there was a role for specific bugs, but unfortunately they didn't find the same bugs. So there's a big question of how the gut microbiome may play a role in cancer and certainly the treatment of cancer. And we look forward to Dr. Wang's presentation.
Thank you, Dr. Yang, for the introduction, and good morning, everybody. I really enjoyed the first lecture from Dr. Stoneman and his fancy slides. A nice, fantastic overview of the big topic of microbiome. Now I'm gonna switch the gear and focus a little bit more on the particular field. I have the pleasure to give the lecture on the topic of gut microbiome on the cancer therapy related GI toxicity and also cancer response. Perfect. Okay, perfect. Thank you. So as we know, in 2018, the Nobel Prize in Medicine was awarded to the discovery of the immune checkpoint mechanism leading to a new cancer therapy called immunotherapy or immune checkpoint inhibitors. So the concept of this immunotherapy is to shut down the brake mechanism and prolong the active status of the immune cells so that they can provide a more sustained tumor cell eradication. So the first immune checkpoint inhibitor agents was approved by FDA in 2011 to treat melanoma. Since then, it has opened a new era in the cancer treatment field. The overall survival of selected patients can actually reach up to 80% over 8 years period of time. So immunotherapy definitely becomes the most promising therapy to cure cancer in the future. However, the augmented immune cells can also cause inflammatory damage in non-cancer cells, and that's what we call it toxicity or immune-related adverse events. Okay, I'll start to forward the slides on its own. Okay, thank you. So first I want to use this slide to show you the distribution of these toxicities in different organs. As you see that this immune-related toxicity can involve almost every single organ in the human body. On the left side is the mild grade of toxicity. On the right side shows you the more severe grade of toxicity. And the immunocheckpoint inhibitor is being divided into three subcategories. CTLA4, PD1, and PD-L1 depends on the target that this agent is aiming to. So as you see that the skin toxicity and the GI toxicity are the two most common one in the mild grade. And when we look at the more severe grade, the GI toxicity becomes the top one. And here I want to show you the endoscopic findings of this GI toxicities, particularly. The top panel shows you the more severe form of the presentation. As you see that there are multiple large deep ulcerations throughout the colon. The middle panel shows you the moderate inflammation, that the ulcers can be smaller or more superficial. There is diffuse erythema and inflammatory exudates or loss of vascular pattern. The bottom panel shows you the mild inflammation. You see the patchy erythema, maybe a few sporadic abscess ulcers, and just diffuse edema, or even normal looking mucosa. So interestingly, that the patient who had GI toxicities, regardless of the severity of the toxicity, their survival benefit is it's very favorable compared to the patient who did not develop any GI toxicity. And this is shown on the left side of the slides. The difference is, as you see, the significance between 50% versus 15% at 80 months of follow-up. Even in patients with mild GI toxicity without a requirement of aggressive medical treatment, you still see the benefit of survival, which is shown on the right side, the right curve compared to the blue curve. So GI toxicity being considered as a marker to predict that the patient could have a better cancer response to the treatment. So the current treatment options for the immunotherapy toxicities, especially in the GI tract, are corticosteroid as a frontline, followed by the infliximab or vedolizumab. And as we are kind of aware of the drawbacks or the risk of long-term use of corticosteroids, and also the potential increased risk of malignancies with long-term use of TNF-alpha blockers in the field of inflammatory bowel disease. There is also a concern that by using all the systemic immunosuppression may potentially counteract with the immunotherapy's effect and therefore affect the cancer outcome. So there is an increased risk of infections from patients who are exposed to immunosuppression, especially corticosteroid. On this particular slides, I showed you the rate of infections in patients who are treated with long duration of corticosteroid, meaning more than 30 days, versus less than 30 days. The rate is significantly different, as you see, 50% versus 30%. So the goal is to minimize the duration of corticosteroid if we can in this patient who had toxicities. Speaking of the risk of infections, especially during the COVID pandemic, there is also concern that whether there is an increased risk of COVID in patients who had immunotherapy-induced colitis, especially they are exposed to the immunosuppressions. And we did this retrospective study just recently, and this study was published about a week ago. We looked at a total of 69 patients within the study window of December 1st, 2019 to April 30th, 2020. As you see, 59% of patients has underlying lung disorder, and patients are evenly distributed among melanoma, GEO cancer, and thoracic cancer group. And 77% has stage 4 cancers, even 14% has neutropenia with absolute neutrophil counts less than 1,500. Majority of the patient has at least CTCAE grade 2 and above diarrhea and colitis. And among our cohort, 65% of patients exposed to corticosteroid, and the 35% has used vedolizumab or 9% used infliximab. And interestingly, as you can see, a majority of our patients actually have a very good compliance to social distancing policy. As you see, 86% of patients wear a mask when they go to public, and they have following the frequent hand washing throughout the day and minimize their exposures to contacts other than the household. And 55% of our cohort has been tested for COVID for different indications, and none of them came back positive. And the rest of the patients were not tested for COVID because there was no COVID concerns on the recent visit to MD Anderson. And there is no COVID-related death as well. So now I'm going to focus a little bit about fecal transplantation for this particular patient population. So why I think that a fecal transplant will work for the patient who had cancer immunotherapy-induced colitis. So there are already animal studies. I find this is kind of difficult for me to control the slides because it's constantly doing auto-forwarding. Okay, so there are already animal studies showing that the mice that are treated with CTLA-4 agents after inoculation of cancers and followed by antibiotic treatments and the bacteria combinations in their fed, there is a significant benefit of the tumor response in certain group of mice that were treated with a specific bacteria combination. And similarly, in the mouse model that has the colitis from the checkpoint inhibitors, which is on the middle side of the pictures, the combination of bacteria can also facilitate the healing of the mucosa inflammation. And in human subject, particularly in the study in the melanoma patients population, they were treated with immunotherapy and then followed longitudinally. The stool were collected and analyzed. As you see, the patient who had colitis later on has a different bacteria composition compared to patient who did not develop colitis. So we performed the first fecal transplant for the indication of immunotherapy induced colitis in cancer population in June 2017. We performed this fecal transplantation through colonoscopy because the reason that we can also have a thorough evaluation of the mucosal inflammation before and after the treatment. And as you see, the chocolate color liquid in the syringes are the healthy donor stool, and we deliver that into the right side of the colon. And this is an outpatient procedure. Patient can go home after the procedure. So I want to show you the endoscopic findings before and after the fecal transplant. The top panel shows you the endoscopic findings at a time of initial colitis diagnosis. As you see, there are multiple large deep ulcerations and active bleeding. The middle panel shows you the endoscopic findings after 3 months of immunosuppressions, including high-dose corticosteroid IV and oral, and two doses of infliximab and 1 dose of vedolizumab. And the bottom panel shows you about a month after fecal transplant treatment, you see a nice resolution of the mucosal inflammation and the healing of the ulcers. And patient symptom has resolved within 10 days after the fecal transplant treatment. So we did the metagenomic analysis on the first patients. And as you see that there is a nice engraftment of the donor stool on the recipient side on day 10 and day 53. As you see the yellow color from the donor side, this is the recipient baseline. And specifically when we look at the specific bacteria, you see the Akkermansia is the one that stands out, and same as the Bacteroidetes. We did the immunohistochemistry. We found there is a nice downregulation of cytotoxic T cells, which is CD8 T cells, after the fecal transplant, and the inhibitory T cells with Treg, and you can see a nice increase after fecal transplant. And here I want to show you the second case. The top panel shows you the multiple large ulcerations again. And the second panel shows you the endoscopic findings after 5 months of the immunosuppression treatment. On the third one is 5 weeks after the first fecal transplant. The last one shows you the 3 months after the last fecal transplant or the second fecal transplant. And the patient's symptom has resolved way before we do the repeat colonoscopy. So we did the similar stool metagenomic analysis, and it shows the similar pattern. As you see, the successful engraftment of the donor stool on the recipient side, even on day 67. And after second fecal transplant is day 78. And the bacteria that stands out on the second case is actually slightly different from the first one. As you see that this one is a Blottia is the one that stands out, and also some of the other bacteria. But Bacteroidetes also increased on the second fecal transplant. And the immunohistochemistry studies also shows a similar change of the inflammatory cells. And here I want to show you the third case. This patient has, oh my, this is, I'm not sure what is going on with the slides. Okay, the third case of the fecal transplant. This one shows you diffuse inflammation in the colon on the initial diagnosis. And then after 2 months of immunosuppression, including the corticosteroid and 3 doses of vedolizumab, you see there's a new development of deep ulcerations. And this is 2 months after the fecal transplant, the inflammation resolved and the ulcers are almost healed. So this is the first case. There are ulcers in the small bowel and the colon at the time of diagnosis. The patient was started on corticosteroids as the front line. However, patient developed candida infection in the esophagus and also C. diff infection in the colon. So we're not able to continue the immunosuppression or escalate. So we decided to do fecal transplant, and 6 weeks later, you see a complete normalization of the colon. So far we have performed fecal transplant for a total of 15 cases. For a patient who had refractory colitis that have failed previous steroid and infliximab vedolizumab. As you see, the majority of these patients are GU oncology patients, followed by melanoma and thoracic cancer. And 60% of patients receive the combination of CTLA-4 and PD-1 or PD-L1. And 93% of patients has very high grade of diarrhea, 3 to 4, and 60% has grade 3 and 4 colitis. 93% of patients require hospitalization for this colitis-related symptoms, and all of them has been treated with corticosteroid, infliximab, or vedolizumab and did not achieve the response. So the median time from the initial GI toxicity development to the fecal transplant treatment is about 75 days. And our success rate to achieve symptom improvement after fecal transplant is 73%. And the median time from the fecal transplant to symptom improvement is about 10 days. There was no reported serious adverse events related to fecal transplant within 7 days and 30 days. So now I'm gonna spend the next few slides to talk a little bit about the gut microbiome and cancer development and cancer response to treatment. So there are already evidence supporting that the gut microbiome alterations can be associated with the cancer development, and specifically the breast cancer, colon cancer, stomach cancer, and hepatobiliary cancers has been studied, and that's related to stool dysbiosis. So I put a summary table here. These are the 3 kind of recent studies published with in the same journal within the same around the same time. So all of them studied the association between the gut microbiome and the cancer response. As you see, some of the studies are focused on melanoma, some focus on different type of cancers other than melanoma, and all of them has been tested their hypothesis in the mouse model, and some included human data as well. The general features is that the higher gut microbiome diversity is associated with better cancer response to immunotherapy, and antibiotic use around the time of the immunotherapy treatment can significantly compromise the progression-free survival and overall survival. And interestingly, the favorable bacteria that are associated with good cancer response all differs among different studies. And all of the studies have done the fecal transplant in the germ-free mice by using the stool from the patients who had a good response to the immunotherapy, and they have a pretty consistent findings that this fecal transplant treatment can significantly slow the tumor progression and improve the efficacy to the immunotherapy. So for the underlying mechanism, also 3 studies have found a consistent type of evidence that there is an increased expression of cytolytic T cells in the tumor bed. So this is another kind of summary about the same theories that I just reviewed in the previous 2 slides. So higher gut microbiome diversity is usually associated with better cancer outcome, and particularly there are certain bacteria that has been studied and shown to be associated with a worse cancer outcome, and these are the ones that are associated with better cancer outcome. And these are mostly related to the increased TDA positive T cells in the tumor bed that is associated with a better cancer outcome. So there are different ways to convert this deleterious microbiota composition to the more favorable pattern so that we can help to improve the cancer response. And that can be through the fecal microbiota transplantation or dietary changes, probiotics, prebiotics, and other medications. And here's the summary of the selected clinical trials that is aimed to modulate the gut microbiome in the cancer treatment with the goal that we're able to improve the cancer response. As you see, these trials are being focused on multiple different cancers, including melanoma, breast cancer, and GI cancer. And these studies are all over the world. So we're excited to see the results of this study. So there will be a potential need to do the combination of fecal transplant together with immunotherapy to treat for future cancers. So the take-home message is that microbiome plays a role in the cancer response and cancer therapy-related toxicity. Specific microbiome signature for favorable cancer response and less toxicity is to be defined. fecal transplant can be an effective treatment strategy to improve those conditions. Thank you.
Is my speaker on? Thank you. That was amazing.
Yes,
Both of you are amazing.
Thank you, Dr. Wang. It was a terrific talk. So should antibiotics be given to patients routinely with the colitis, or do you advise against that, especially if they're going to go into immunotherapy?
So based on our own studies and also other studies, that antibiotic use without a clear indication is not encouraged, especially for immunotherapy-induced colitis. I would never recommend to use antibiotics as an empirical coverage unless you find a specific pathogens in the stool microbiology evaluation.
Okay,
Otherwise,
I know you talked about gut disease, but it's my understanding that for some lymphomas and other diseases, antibiotics are routinely given just because there's a feeling that the immune system is suppressed. What are your personal thoughts about that?
Yeah, that's a good question. So I take it as this is a completely different patient population, because for patients who are exposed to immune checkpoint inhibitors, theoretically their immune function is actually boosted. They are not immunocompromised. So the lymphoma or the leukemia patients, if they have a deconditioning treatment and then stem cell transplant, they are a lot of them are immunocompromised or even neutropenic. So that's a little bit different. They will have a higher risk of having all sorts of opportunistic infections. Empirical antibiotics can be a life-saving type of measure. For a patient who had received immune checkpoint inhibitors, frequently we see that the infections that was identified in the stool microbiology evaluations, most of them are, I consider they are playing more like a bystander type of role instead of triggering the symptoms. So the antibiotic treatment that we have used in certain patients did not really improve their colitis symptom at all. Eventually, they still use the immunosuppression to reverse this immunotherapy's effect. So I consider this colitis is not really infection triggered. It's more like an autoimmune type of underlying mechanism.
Okay, and one thing you haven't mentioned, I'm just curious if your group is looking into this. Are you considering the metabolome or the transcriptome of the biome or the host metabolome that can result from changes in the biome?
There could be. I don't think that we have data for that. We are actually in the process of obtaining those data from our colitis patients.
Okay, let me see if there's any other questions that have been linked. Okay, I think we're going to go ahead and take a 5-minute break right now so we can solve the slide questions, the slide advance, and give everybody a bathroom break. So